I am so honored and excited to interview one of my newest medical advisors, Dr. Lauren Kopicky from Cleveland Clinic. She's a breast surgical oncologist, and she is dedicating her time and expertise to help us all understand the mystery behind the lymph nodes. So, Dr. Kopicky, can you please tell us a little bit about yourself and why you're a medical advisor for Look Locate?
Thank you, Cynthia. I'm very happy to be here. Such an important topic for us to discuss.
Mhm.
So, I am a breast surgical oncologist at the Cleveland Clinic. I trained in general surgery and then specialized in breast surgical oncology. And I've been excited to join Learn, Look, Locate to be an assistant to you to get good information out to anybody affected by breast cancer, to be able to give good information, to be
Yeah.
empowered to make decisions for either themselves or loved ones.
Yeah, I appreciate that. We need you because it's not a lot of time. We don't have a lot of time with the doctors and the surgeon and hearing the diagnosis. And so with that, I'm going to dive in and I'm going deep. We got a lot of great questions because a lot of us want to know. We don't understand the mystery behind the lymphatic system, predominantly the sentinel nodes. So we're going to cover a lot of topics. First and foremost, when you first meet somebody diagnosed with breast cancer, how do you actually explain the role of the lymph node when it comes to, breast cancer and the diagnosis in general in simple, plain language? Like, what is this thing and why is it so important?
So, our lymph nodes are little, I guess, kidney bean type structures that
Mhm.
are part of the lymphatic system, which acts as filtration, filters fluids, and also acts to filter out any unwanted particles, whether that be diseases or abnormal cells. And they also function as part of our immune system, creating lymphocytes. And so they're very important in the assessment for a patient with breast cancer to determine in the drainage pattern from the breast to the lymph nodes, specifically to the axillary lymph nodes. Axilla is just a fancy word for armpit where these lymph nodes live.
Okay.
And so we're curious about them because we want to know if any cells have started to drain or be filtered from the tumor itself in the breast to that regional basin, which is in the axilla. And we're very mindful of this area of lymph nodes because it also drains, there's crossover and drainage from the arm as well. And so we'll get to a little bit of the risks as far as what happens when we assess these lymph nodes or if we remove them.
Hmm. Hmm. So, a lot of us fear the word spread. So, how do you help patients understand the difference between cancer cells in the lymph nodes versus cancer that has spread to other parts of the body? So, I'm going to just touch on my own personal experience. I had a micro metastases in my sentinel node. So obviously the cancer left the original tumor site. So can you explain that as well as the difference between cancer cells in the lymph nodes versus, how do we know, in other parts of the body, the difference?
Sure. So when we are concerned about spread of cancer, of any type of cancer, we talk about this in terms of a local risk or local regional. So I'm going to use that word a little bit today because the
Okay.
lymph nodes underneath the armpit are part of our local regional assessment to stage and treat breast cancer. There's also risk of a distant spread of disease, and that would be to other parts of the body. And we look at the lymph nodes and the local regional assessment, so the breast and the lymph nodes, to give us some clues as far as the extent and the risk for something distant in the body. Now, the fact of any invasive cancer is that it's possible that there are cells that are already circulating in the body, and the hope is that our body's immune system is fighting these. And it also supports the rationale or role of whole body treatments. When I'm meeting with patients, I talk about systemic treatments meaning treating the whole body. So that if even one cell has escaped through the bloodstream, is hanging out somewhere else, that's what we use those whole body or systemic therapy treatments for. So those are
Mhm.
things that act on those receptors of the tumor cells. Um, Estrogen, progesterone, HER2. So we're talking endocrine therapy or estrogen blocking medications or chemotherapy, or sometimes both for patients, depending on what's needed for treatment.
Mhm.
And so assessing the local regional area to determine if any cells have started to spread, and in your particular case, a couple cells had deposited in a lymph node, but not a high volume. And so that's indicative to us of a little bit more of an aggressive type of a cancer. It doesn't change the type or behavior of the cancer. So we call that tumor biology, but
Mhm.
it lets us know how how advanced it is within the body.
Okay. Okay. So the question I have personally is, when what is scary, I think, for a lot of breast cancer patients are they only took the sentinel node out, and and then they thought I had clear margins during the surgery, and then the pathology showed 200 cells or less of micrometastases in my sentinel node, and then I sit here and go, well, how does the surgeon know that it didn't go into the next node? Can you explain this string of commands? Maybe that's, like, how does this all work? I'm getting away from the cheat sheet here, and I'm just going for
Yeah.
patient-friendly language.
So we often describe the sentinel node, if you think of a sentinel of a fort, it's kind of the first person standing guard.
Yes.
And so fact of the matter is we've got kind of a whole chain of lymph nodes. And if we look at an illustration in a textbook of these little kidney beans that kind of have this little network between them, it looks very simplistic in that diagram of here's the breast and here's it draining up towards these nodes. And it's not as simple as one after another, kind of in a succession, because then I would agree with you. How do we know that the first one, if it has some cells, the next one didn't? And truthfully, when we make our incision and map the lymph nodes, and mapping the lymph nodes means a couple, one or two or multiple injections into the breast to allow us to map that drainage to identify the lymph nodes that are draining the breast. So there's certain materials, and so I'll just kind of take a step back and describe the sentinel node procedure, and then we'll circle back to
Yes.
your question. So at the time of surgery or right before, we have either a radio tracer material or blue dye or ICG dye, or a combination that we can use to do an injection either in the skin near the nipple or behind the nipple that then gets massaged into the breast, and that drainage that we talked about. So the whole purpose of the lymph system is draining fluid.
Mhm.
The dye or the tracer gets taken up and starts to travel up to the lymph nodes. So then when we make our incision underneath the armpit to dissect down to where these lymph nodes live, we are either visually looking for the blue dye or green dye, or we have a device that helps us look for this tracer. It's kind of like a little Geiger counter. And
Mhm.
that helps us identify which lymph nodes are actually draining from the breast. And there's a little bit more specific about technique about how we know which ones to remove or how many to remove. And it's based on that drainage of does it have the dye that we injected or the radio tracer or both? And then what is our threshold for how many we remove? And for most women, it's between one and four. If we're removing a higher number than that, the risk of lymphedema goes up. And so everybody's different. There are times where we're only getting uptake of the tracer or dye into one lymph node, and that's the lymph node that we remove. And sometimes it's a couple more. And so though that's how we know the ones that get tested, because we don't need to remove normal lymph nodes that are not draining the breast, because we don't need to remove them if they're not involved in the drainage pattern for assessment. And we've got multiple levels of lymph nodes underneath the arm. We classify those by their borders from an anatomic standpoint. And so we're really talking about kind of the lower lymph nodes is typically where the sentinel nodes live. And so that's how we identify which ones to remove. And so it's not always that it's in a succinct order of one after another. It's just when we get in there and we're pulling the tissue, we're looking for either visually with those dyes or with our device, the radio tracer, and that's how we identify which ones to remove.
So would you say if someone like myself I know I got the blue dye in there, she explained it, but at that time I
Mhm.
had no idea what that meant. So would you say that the blue dye did not light up in the other lymph nodes? But, if I had clear margins in surgery, but then didn't afterwards, did the blue dye not work? I don't know.
No, the blue dye worked. That's how they identified the sentinel lymph node. So the dye helps to highlight which nodes are draining from the breast. So the nodes that did not have dye in them were not draining the breast. So
I
that's why
see.
those didn't need to be removed. And so that's where that crossover of nodes draining the arm is also important to know because we want to leave those alone.
Okay. So when someone's newly diagnosed, how do you explain all of this to them? Because there's thing, and I did, as you know, I've talked about our interview and that most people are really concerned about this. So can you just explain, as you did earlier, but the lymphatic system and what the breast surgeon is actually really looking for? Is it how the cancer behaves? I mean, what is this? Is it a window into treatment? What is it?
So, status of the lymph nodes is historically very important for staging, and it still is today. So, our staging of breast cancer starts with our exam and our imaging. And if you look at the Joint Commission on Cancer and their guidelines for how we stage breast cancers. And every patient that we see, we put in the information to give us their stage. So when patients are seeing their physician for the first time and they want to know what stage they are, it's incorporating some of these details. So T, N, and M
Yeah,
are
target
those
tissue.
letters that we use. And T stands for tumor. So that's solely based on the size of the tumor, and we use our imaging and or exam for that. N is for lymph nodes. And the way that we assess that is whether or not we feel any. And if we do feel any, there's a distinction between feeling them and if they're clumped together or matted, we call that. And then M stands for metastasis or spread elsewhere. So if somebody has evidence of disease elsewhere in the body, then that would be classified there. Now, it used to be solely breast cancer was staged by TNM, and we called that anatomic staging because it was really based on just anatomy of how big the tumor was and if the lymph nodes were positive or not. Now, our staging system has been updated over the last several editions to incorporate what we call tumor biology. So that's things that you see on your pathology report, like grade. Grade is
Yes.
one, two, or three. And then receptors. So the three receptors for invasive cancer are estrogen, progesterone, and HER2. And so now it's a very intricate combination of all of these things. So you still have your T, N, and M, and then you have the tumor grade, and then those receptors that all factor in. So you could have a bigger tumor that has more favorable receptors be a lower grade than a smaller, more aggressive
That was me.
tumor. And
Yeah.
so these things factor in and it really goes to putting the emphasis on tumor biology or tumor behavior um, more so than we used to on simply just size and lymph nodes. But it all starts in that initial visit, and it actually starts at imaging. So most patients that come to me have some sense of hearing the word nodes, and a lot of times it's because when they have their abnormal mammogram or they're seen for their imaging appointment, they are not only doing their diagnostic mammogram, but they're doing an ultrasound. And part of that diagnostic ultrasound is looking at the lymph nodes. So
Mm,
we tend to have that information before I even see the patient,
interesting.
knowing that we've done the ultrasound underneath the armpit, and we get a sense for whether those look normal or not.
Let's talk about that for a second, because I don't share this often, but a year after my diagnosis, I had a terrible skin allergy from the radiation and the stuff I was using, and I was able to get another PET scan, and I had an uptick in my good side under the armpit, and they did an ultrasound, and I had a lymph node that was BI-RADS 4. Can you imagine? It's literally probably like 7 months. So I'm
Mhm.
sitting here thinking, I'm going through this all over again. But I think what's happening with breast cancer patients, there's a lot of terminology coming at us. So seeing BI-RADS 4, doing the research myself to understand that that's suspicious.
Mhm.
And yet it turned out to be nothing. So how do we comfort people? Because I recently launched a whole page on my story on breast density and the whole BI-RADS category of 0, 1, 2, 3, 4, 5, 6, and obviously 6 being, malignant. And, how do you decipher and how do we understand that, the lymph nodes, if you maybe are on some new medication, can, flare up, or, they're
Mhm.
sensitive. So I want to talk about that.
So I would take it out of the breast cancer space for a minute and just reference anytime you get a cold or the flu or sore throat, you feel your cervical lymph nodes, cervical meaning the ones right here, and you feel your lymph
Okay.
nodes enlarged. And that means that they're working, they're fighting something, they're trying to filter out those
Ah,
toxins. And lymph nodes anywhere in the body can act that way. And so if you had, there's a lot of reasons a lymph node could swell. Now, if it is persistent, or in your case, they thought maybe there was some activity on PET scan, then we want to get a closer look at it. We saw a lot of women who had lymph nodes pop up on their screening mammogram within the months and year after the COVID vaccine came out because women were getting vaccinated. And just as you would expect, your immune system kicks up or your lymph nodes kick up because you're altering your immune system by trying to purposefully mount this response. And so we were seeing a lot more swollen lymph nodes that were picked up on our mammogram because the mammogram catches the lower part of the axilla. And we had to do a lot more investigation then and kind of create protocols of what our threshold was for kind of monitoring these. So injections in the arm can cause lymph nodes to swell, reactions, any type of injury or wound to the upper extremity or your arm can cause those lymph nodes underneath the armpit to swell. So I would say if anybody has any feeling on exam that they think that their lymph nodes are swollen and it's kind of persists, not explained, we definitely want to look into that. And so then with imaging, the BI-RADS system is designed to kind of dictate or assess level of suspicion for malignancy, and then also to give guidance and to follow up. So BI-RADS starts with 0. 0 means we need more imaging. We haven't completely assessed this. So for a woman who comes in and has an abnormality on their annual routine screening mammogram, they would say that's a 0 because they see something and they need to investigate it further. So it means the workup's not complete yet. BI-RADS 1 is negative, meaning nothing. BI-RADS 2 is benign, meaning something, but it's benign and not worrisome. BI-RADS 3 means that it's most likely benign, but we don't quite want to wait until next year's mammogram. We want to do a short interval follow-up. And then there's a big kind of step between 3 and 4. 4 gets the category suspicious or the term suspicious. And it's then can be further divided into ABC based on level of suspicion, but not everybody reports that distinction. So for most, it's just a BI-RADS 4.
Mhm.
And I like to describe to patients that a BI-RADS 4 usually means that we want to stick a needle in to get a sample. So we're not And there's varying degrees of suspicion there, just as I explained of ABC, but you may not have an ABC. And so there can be a wide range there between being a little bit more suspicious, this could be a malignancy, versus it's more suspicious than a BI-RADS 3, where I just want to follow it with imaging. I'd like to get a sample and then I'll feel better that it's something benign. So there's a big variation in BI-RADS 4. BI-RADS 5 is a high level of suspicion for malignancy. So I kind of term that, malignancy till proven otherwise, although that's the entire point of the biopsy. And it's a scenario where if we biopsied that and we didn't get a cancer diagnosis, we would be concerned that doesn't match. So it means there's high enough level of suspicion, and so that warrants, if it's positive, then obviously a consultation, and then if it's negative and discordant, then a consultation. So needs a lot more attention. BI-RADS 6 then is what we'd say biopsy proven malignancy, meaning that they're getting imaging as part of their workup and they already have a known cancer. Um, so we already know that there's that diagnosis.
So, Dr. Kopicky, when it comes to breast cancer, I had no idea I had a walnut-sized tumor. I talk about it all the time. And then I had no idea that I had cancer in my lymph node. Is there any way for us to actually know if there's cancer floating around in the lymph nodes? Is it hard if it moves up there? Could I have felt those micro metastases? Or even if it was bigger, thank goodness it wasn't. But,
Mhm.
if I was in my armpit, you know what I'm saying? Like,
So
could people do self breast checks to understand the lymph nodes system to understand if there's like a tumor in there? I know that sounds like a crazy question, but
great. No, great question. So on occasion, that's how somebody finds out that they have breast cancer. They feel some swelling underneath their armpit, and then that
interesting.
prompts the diagnosis. And so it really depends. I've
Interesting.
seen many different combinations. You could have a very small tumor in the breast and a big deposit in a lymph node, something as small as a micrometastases, or the majority of lymph nodes that are involved by the microscope aren't going to feel abnormal. I would say, as a breast surgeon who's felt a lot of lymph nodes both on exam and in the operating room, I can get a sense in the operating room if something feels firm and more suspicious to me.
Okay.
But the lymph nodes don't, it's not always that the entire thing is replaced by cancer. So especially in your case where you just have some tumor cells, your lymph
Yes.
nodes are going to feel normal because that's really a microscopic diagnosis. I mean, we're talking less than our
Pinhead.
micrometastases of
Yeah.
less than 2 millimeters of disease. So teeny, tiny. And so sometimes that means that in this kidney bean lymph node that there's only one little deposit and the rest of it's clear. So if we have any suspicion on the initial diagnostic ultrasound, then we would do a biopsy of that lymph node at the time of the workup of the breast cancer. So we can do a biopsy of a lymph node if we have any abnormality that we detect on imaging.
Can I just share with you that as someone who has been dealing with a cancer diagnosis and 6 years later, in the back of my mind, knowing that I had a micrometastases, just you doing this visual, I'm going to cry, and showing me that it's hanging out just this little bit is comforting because
Mhm.
I don't know the scale, right? So thank you for that visual and for anyone who's gone through that or trying to understand what that sentinel node is doing, what it's telling us. Because again, I thought I had clear margins. I'm sure many of us who have found out that, oh, there was cancer in the sentinel node, that to understand that if it's a quote micrometastases. Now, let's just say it's not. Would the um, sentinel node be filled like a tumor? You know what I mean? Like, could it get
It
that?
can be. Yeah,
Okay,
it can
okay,
be. And that's where our imaging tells us. So, I described like the kidney bean, and then in the center of the lymph node is what we call the hilum. That's where all the blood vessels come in. And then around that's kind of like if you think like a crunchy coating on an M&M, the cortex. And so when that cortex starts to get thickened, that becomes abnormal. And so that's what cortical thickening is what we
I
call
saw
that.
that. I saw that.
Yeah, so a lot of
Yeah.
women might see that in their report, if there is a certain threshold that we would then biopsy. So if somebody has breast cancer detected or a breast mass detected on their mammogram and then they get their ultrasound and they have some cortical thickening, that might be a scenario where the radiologist recommends a
What
biopsy
does
of
that
that
mean?
lymph node.
Say it again. Cortical.
So cortical thickening, it means the cortex, the outer layer of that lymph node, is started to get bigger. And
Why?
so because it's reacting to something.
Okay.
So tumor might be building up in that area, and then we call the hilum gets suppressed. And so there are times where we can look at an ultrasound and we see a completely abnormal looking lymph node, meaning it doesn't have that nice little hilum there. It's just thickened cortex because it's harboring. Remember, it's kind of like uh, your guard system. So it's harboring tumor there. And so there are times that in surgery, I can feel this lymph node and it's very firm and it's very full of tumor. Um,
Okay, so let's talk about that. So let's talk about the sentinel node. So you have a tumor, the cancer cells leave, go to the sentinel node, and then when we talk about early detection and screening and all that, if you're sitting kind of maybe like I was, even though I was getting my mammograms, but I
mhm.
kept getting normal. Um, I even said last night, like, what if they never found it? Even though it was, quote, a big but sleepy tumor, over time, I want you to talk about what happens if that cancer, it's the tumor's here, leaves, goes to the sentinel node, and then just sits there. Tell me what happens. Does the tumor bust out of the lymph node? Does it drain into the second lymph node, the second node? What happens?
So it can. I mean, this is just kind of a clue in for us of the tumor spreading. So I often tell patients if your tumor has spread to your lymph nodes, it's possible it's only deposited there. And again, I go back to what I said about any invasive cancer has the potential to already have cells circulating. That's the reason for an invasive cancer of treating with whole body therapies and not just surgery alone for most
Okay.
women. Um, and so this is our clue that it's started to spread and it does guide local regional treatment. So if we knew at diagnosis that somebody had lymph nodes involved, it may change the extent of our lymph node surgery. It may change whether or not chemotherapy is indicated, and it may change whether it's indicated first or after surgery. And it does change the radiation field. And so it depends how many lymph nodes are involved when we do the sentinel node procedure. Remember, I said average about 1 to 4. So, say we have 4 lymph nodes, only 2 are involved, 2 are not. That's a good representation of there being a low amount of lymph nodes involved. And so, in that particular scenario, not an indication that we would need to remove all of the lymph nodes. And
Mhm.
so, we're trying to remove the disease that we know is there. So hence the reason for a good exam and the ultrasound to start.
Mhm.
Um, but it's just one component of somebody's treatment.
I think as I'm listening to you, and many of us diagnosed with breast cancer don't realize the complexity around this disease. And because if the tumor starts in the breast and leaves, there is this whole you know, I don't know, travel railway of what could
Mhm.
happen. And I don't think we have time to process this. So I really appreciate you helping us to understand because it's a lot,
It is a
right?
lot. It is a
Yeah,
lot. And I think that it's hard to know those questions to ask at a first visit. And
yeah,
You know,
for
I
sure.
I even as the surgeon may not go into this kind of intricate detail just about the lymph nodes because we have a lot of other things to talk about. So it's important to know about, and I
Yeah.
and I think that you know, historically as surgeons, we thought surgery was the cure for cancer. So women were getting very aggressive surgeries, removing the entire breast, all of the lymph nodes, even the
Whoa.
muscle underneath, because we thought that we were
Oh,
an aggressive surgery led to a better outcome, and we found out that that's not the case.
interesting.
And that's because of this concept that an invasive cancer is already a systemic problem, and hence the now focus on tumor biology and treating the type of cancer that it is. So if we think about those receptors I described, the three receptors, estrogen, progesterone, and HER2, if you think about that like a little antenna on a cell, it tells us how we can target these cells. And I describe to women, if there is one rogue cell that is somewhere else in the body, that's what these treatments target as well, and basically starve them by latching onto these receptors and blocking it. Um, historically, even after we moved away from a more aggressive surgery, we were still doing full lymph node removal because we wanted to know what all of those lymph nodes were doing. We thought that women had better outcomes with that, and we realized, stepwise that more surgery wasn't always the answer.
Yeah.
And that is how we eventually developed this sentinel node procedure because somebody thought at one point, why are we removing all of these lymph nodes, normal lymph nodes, for the majority of women who don't have lymph node involvement? And can we do less of that? Um,
Ah,
and and part of that, I think, was the drive because of the um, unfortunate side effect of lymphedema, which is
yes.
arm swelling. And remember earlier I mentioned the crossover because the lymph nodes underneath the armpit some drain from the arm, some drain from the breast, and some drain both. And so we were inadvertently, by thinking we were doing a good thing by removing all of the lymph nodes, thinking they could be harboring cells from the breast cancer, we were
Causing.
then disrupting the flow of fluid from the arm. And, the severe lymphedema can be very debilitating and really a negative impact on quality of
Yeah.
life.
Yeah. There's not enough. I'm grateful to have James Xavier's. He's a lymphedema specialist, part of the medical team here of expert advisors, because there's just not enough discussion about it. And I think, as you had mentioned earlier, the intricate detail and the information, here's another thing we need to think about. And it wasn't brought up to me till way afterwards. I
Mhm.
mean, not at all. Like the risk of and understanding, what that really meant. But when you mention all of this, can we talk about the de-escalation of, whether it be surgery or treatment, and the kind of the shift towards maybe the elegancy of less is more, similar to what you said? How does that work, and how does that comfort patients? Like, as I'm listening to you, I'm like, okay, this is great, but I only have one sentinel node, but how do I know they're not in the others? And then I'm like, well, great, I didn't get lymphedema. There's a lot of
Mhm.
backtracking in my mind. But for a newly diagnosed patient, with the way surgeons are going now, I know this is a lot of your work and research. So I'd love to hear more about that.
Yeah, so I think a lot of patients share what you just mentioned of, we want to know, but we
Mhm.
also don't want to cause unwanted side effects, but we want to
Yes.
know.
Yeah, we
And
want to know everything.
and so it really does go back to, really focusing in on tumor biology. So we have some new data. We've had some guidelines that were set forth actually as long ago as 2016. So for going on a decade now, we've favored not checking lymph nodes in women over 70 with a very small estrogen-driven tumor. And of course, this is, looking at all of the information, making sure that the lymph nodes feel normal, that they look normal by imaging. If there's any suspicion,
Okay.
something may need to be biopsied. If there's any negative or high risk features on the tumor, then they wouldn't qualify. So we've started investigating this as long as a decade ago of not adding complexity to the procedure because that information doesn't yield change in treatment. And part of that, I think, drive for that was the advancement of our what we call genomic profiling. Genomics,
Nobody
genomic
knows what that
profiling of
means.
a tumor means the genetics of the tumor itself. So if you've heard of, and I know you've talked about Oncotype mammoprint, so these are
Yes.
genomic assays. These are tests that are run on the tumor that really give us a better risk profile than simply the size of our tumor, lymph node status. It's really the genetic makeup of the tumor itself, and that gives us a risk um, and guidance for treatments. And so historically, before we had this test, the decision for chemotherapy was based solely on that T and N part of the staging. And so we got that information from surgery. So if you had a tumor, let's say greater than 2 centimeters or lymph nodes involved, you were put in the chemotherapy bucket. Whether or not we thought that
Oh,
we just thought everybody, and we only knew what we knew then. And
how long
so
ago was that? How long ago?
well,
Aside from,
prior to the studies that came out for Oncotype and Mammoprint, so at least a decade.
so people were over
So we
chemoed.
had the Taylor RX study and RX Responder. So these were the Oncotype tests. Mammoprint has tests as well. And what this did is it really spared a lot of women unnecessary chemotherapy. So it looked at the stratification of the score and whether or not people needed chemotherapy based on the score. Not, and so that's where I mentioned before or said the phrasing that you can have cancer in the breast and the lymph nodes. Doesn't mean it's gone elsewhere, and it doesn't necessarily escalate to needing chemotherapy anymore. So even if you had lymph nodes involved, it may still be a lower risk tumor that may have just gone to the lymph nodes because it had been slowly
Well,
growing for a year or 2 years, and it's not that it's necessarily a more aggressive type of cancer, it's just that it had been there long enough to start traveling. And so those tests have made a lot of advancement to say that we may or may not even need the nodes removed in otherwise, again, that phrasing clinically node negative. So we've done the exam, we've done the imaging, we have no suspicion that there's any lymph nodes involved. Um, that test has helped us to determine, who it's safe to not check lymph nodes because that information we don't prioritize that anymore like we do this test. We've also, I think, started specifically looking at this patient population because we have some studies looking at patients in this specific age range with these small tumors who had either a complete lymph node dissection or no lymph node surgery,
interesting.
and
Okay.
their outcomes were the same. Um, and
Wow.
and this is also kind of another a specific patient population where we've also looked at not needing radiation. And so we started our exploration there. So this whole concept of de-escalation really started in this population, 70 and older with small estrogen-driven tumors, because I think we found that a lot of women in later decades of life don't tend to die of their breast cancer. They might die of another cause. And so why are we over treating the breast cancer and not extending their life, but causing side effects from our
Yeah.
otherwise well-intended treatments or procedures? So we started the exploration there. And we now have two additional studies that actually drop the age range down to looking at patients 50 and older and omitting lymph nodes. But these are still, if you look at the studies, these are still women with very small estrogen-driven cancers
Okay.
without any high-risk features, one tumor, not multiple tumors. And I think predominantly this has been postmenopausal women. So even though we went
Right.
down to 50,
Okay.
um, I think there's still a little bit of discussion about maybe what to do with younger patients. Um, and so the caveat to de-escalating surgery by not checking lymph nodes is we don't want to inadvertently escalate something else. So in each of these studies, the patients who had a lumpectomy and omitting the lymph nodes, they all got whole breast radiation, meaning
Interesting. Okay.
radiation to the entire breast. And that actually captures the lower part of the axilla or armpit. Nowadays, we also have partial breast irradiation. That's a shorter course of radiation that treats really solely based where the tumor was, and it spares the rest of the breast tissue. And there's a lot less side effects to, underlying heart and lungs. And so I think it's important for us to recognize that while omitting the lymph node part of the procedure because we don't need that information might sound like a great idea, we don't want to then have unnecessary additional treatment because we didn't know for sure. So it's very much what we would say a multidisciplinary discussion. All members of the team need to be on the same page.
Okay, so
And
it's a
I
big
certainly,
yes.
when I see patients and think, hey, that could be an option for them that we don't need to check lymph nodes, they look and feel normal. Um, I make sure with the rest of the treatment team that that's not changing any of their
Okay.
recommendations by not doing that.
Wow, that's a lot. I mean, but
So a lot is changing.
yeah, and it
And
does.
I think that our imaging is so good. We're seeing a lot of early stage breast cancer. So we're catching things early, and we're really just trying to spare interruption to the lymphatic system when we don't need to.
Yeah, I love hearing you say that because again, we're so overwhelmed with the diagnosis and trying to understand it that the lymphatic system is just so critical. That's why this project that we're working on is, I think, really
Mhm.
important. I have a question as I was listening to makes, this is pretty out there, but what makes the cancer cells break away from the tumor to go into the lymphatic system? Is it just time causes that?
So
Do you
time
know?
can, aggression of the tumor and how it breaks through the milk ducts or the lobules in the breast and gets into the bloodstream. There's a process when a tumor is developing called angiogenesis where, the tumor starts to create its own blood supply and that's where I mentioned that I don't say that to scare women, that once you have an invasive cancer, it has the potential to spread. It doesn't mean that it has or that it will, but that it could. And just to, again, I have patients see me who say, well, let's just take it out and be done. And yes, surgery is part of the cure of breast cancer, but we very much need to treat and protect so that this doesn't come back. And my goal for every patient is to get to that point to be in remission or say that they're free of cancer. But truth of the matter is we never know, any of us, if we have any bad cells that, our body's naturally taking care of. Um, and so that's the rationale. And when I see patients, I put surgery and radiation on one side of the page for local regional treatments and chemo or endocrine therapy or both on systemic or whole body side of the page, just to illustrate in a visual way that sometimes both are needed because our goals are different. We're trying to prevent a local recurrence, so breast and lymph nodes, but we're also trying to prevent a distant recurrence. And so lymph nodes are just part of that. Breast cancer is one of the types of cancers that spreads predominantly by lymph nodes or by the lymphatic system. There's other cancers that predominantly spread more so by our our blood cells. Call it hematogenous spread.
Okay.
And that affects kind of where things could deposit if they did travel, based on our understanding of different types of tumors.
So once you've been diagnosed with breast cancer and you have a double mastectomy, can you still get a recurrence inside the chest wall from, you can.
Unfortunately, yes. And so I hear a lot from patients that they might opt for a bilateral mastectomy so that the cancer doesn't come back. And I wish that we had 100% guarantee. But our mastectomies, truthfully, aren't 100%. There could still be microscopic breast cells that are underneath or cells that could have invaded into the fat there. And so it's nearly 100%, but it doesn't mean that it couldn't come back in the skin of the chest wall for a flat closure or in the skin over a reconstructed breast. Cells could be harbored somewhere in the body. We see that with certain diseases that cells can be what we call dormant for years, and then that's essentially what shingles is that something's been dormant and reactivates. And so that can happen, and that's why we have our standards of treatment and treat to the prescribed regimens and encourage patients to follow their prescribed regimens because that's what we know to decrease the risk of cancer coming back.
Is there anything we can do, Dr. Kopicky, to be nice to the lymphatic system? I mean, and make sure that, we feel the drainage is good. I mean, we all know exercise, healthy, da 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 da, da, get the stress out. Sometimes we wonder, why did this happen to us? I
Mhm.
think about that often. I'm sure stress had a lot to do with it. Understanding that no family history, I can't run that flag up the flagpole because 85% of us, from my understanding, are getting diagnosed. But to walk around with a walnut-sized tumor and have no clue, is really hard to process. But then to go through all of this and do whatever we can, get enough sleep. But you have any suggestions for us? Because, it's kind of an uncertain journey that we walk and sometimes very scary. I never knew that when you spoke about, the chest wall, even that information has never been brought forward to me. So hopefully I'll sleep tonight. I'm kidding. But, if you could help us to understand, kind of,
Yeah.
I'm not sure if you understand
So
the question, but
the first thing I try to remind women when I meet them at their initial diagnosis is that, you didn't do anything to develop this. Yes, we have some risk factors, but there is really not a single scenario where somebody deserves this diagnosis or has done something to get this
right, of course.
diagnosis. And so
Yes.
um, I hope women understand that.
We
Yes,
need to hear that. That's very
yes.
comforting. Thank you.
Yeah.
Yes.
And, I think it's just like anything in life that we can just try to be the healthiest versions of ourselves. And so
Yes.
you already mentioned a couple of the things that I would highlight. But, it's everything in moderation. Truthfully, we have learned a lot more about cancer genetics over the last decade. A lot of good research coming out about high risk breast genes. 15 years ago, we really knew mostly just about BRCA1 and 2, and now there's more high risk breast genes.
Yep.
Um, but majority of women who develop breast cancer do not have a genetic mutation. And so,
That's the weird
I'm
part.
left to feel like there have to be some environmental risk factors, whether that's in our diet, toxins in our environment, our air that we breathe, and things that largely aren't in our control.
Yes.
And so you're absolutely right. Our lymphatic system is part of our immune system, and so it's working in overdrive to filter out any toxins on a daily basis. And so, then I think, well, if it's busy doing all of that, then if a cancer cell starts to develop, and cancer cells can just
We don't know if they're there.
spontaneously generate, and
Yes.
it just takes one inciting event that turns our cells, kind of the turnover process of cells,
Yes.
into overdrive, and or that we're missing something that stops it. So it's either like foot on the gas, or we don't have the brake, or sometimes a combination. And then it just kind of goes haywire, and our body's trying to fight that. And again, the lymph nodes are part of that system of trying to filter out. So, I think you mentioned getting good quality sleep, staying hydrated, eating as many whole foods as we can, as opposed to a diet full of processed foods. Avoiding carcinogens. We think about smoking, excess alcohol. And there is good data to support those uh,
Yes.
healthy lifestyle changes and decreasing cancer risk. And there's actually a lot of good literature out there now, and a lot of um, progress being made looking at exercise oncology and being healthy after cancer diagnosis actually reduces the risk of recurrence. So there are things that we can
Yeah.
do. It's unfortunately not necessarily always a quick fix.
Yes. Yes.
Um,
Well, I
and
appreciate
and we
that.
always say everything in moderation.
Yeah, that's helpful. All right. I have
Yeah.
one last question because I want to be respectful of your valuable time. Lumpectomy versus mastectomy and lymph nodes. So, how does your approach to lymph nodes differ between someone having breast conserving surgery, a lumpectomy, and someone having a mastectomy?
So our newest data and the omission of lymph node testing. So I mentioned those two newer studies. Those were all in patients who underwent breast conservation, so that meaning lumpectomy. And I think it's important for us to recognize, though, that not all women who undergo a mastectomy need to because of, say, tumor size or multiple tumors in the breast, or any other higher level of aggression on, say, imaging. It may simply be a patient choice. And so I think that while we don't have data supporting that yet in this patient population, I think we can extrapolate or learn from those studies out in patients who have had breast conservation and still highlight treatment or consider omitting treatments based on tumor biology.
Okay.
The challenge when we think about a mastectomy is the way that we map lymph nodes, as I mentioned earlier in our discussion, is injections into either the skin of the breast or behind the nipple. And so some of that does shift in our ability to feel like we've adequately mapped the lymph nodes to check after somebody's had a mastectomy. So you lose the subareolar space. Subareolar means behind the nipple or behind the areola. And that's where we tend to do our blue dye injection. And so the concern is generally that we can't reliably map the lymph nodes after somebody's had a mastectomy. So if, and part of our preparation is thinking, what is our primary tumor size? Are there any high risk features that would make us want to check a lymph node? Is this just stage 0 disease in which we typically don't normally check lymph nodes, except we consider it in the setting of a mastectomy? And it really revolves around that ability to be able to go back if we need to. There has been advancement of a type of delayed sentinel lymph node procedure, specifically looking at patients who undergo mastectomy for DCIS. So DCIS is our stage 0 cancer, ductal
Yes.
carcinoma in situ. And we traditionally don't check lymph nodes in patients who have stage 0 because it's confined to the milk ducts. We don't think that it's gotten out to be able to get to the lymph nodes. So there's a process of injecting a super paramagnetic iron oxide material into the breast at the time of mastectomy, verifying that we have uptake into the lymph nodes. And then once we get the final pathology back from surgery, if there's an upstage or a change in diagnosis, that material is still in the lymph nodes for us to confidently identify them as the sentinel lymph nodes when we go back.
So,
So
wow.
that's been an advancement into to managing those patients. And so that's just one newer technique that can give us a little bit more confidence, if needed, to not check lymph nodes up front, but be able to go back if needed and remove those. So,
Wow.
the best way to prevent any unwanted side effects of lymph node surgery is to not do it. But of
Yeah.
course, there are times that we need to.
Yeah. Yeah. Wow. This is a lot. And I,
And it's
I
a
mean,
very balanced discussion. It's Again, I don't often make these decisions unilaterally. I function as part of a multidisciplinary team. So
Of course.
conversation starts with me, with the patient at our first visit, but we talk about all of those things.
Yeah. Yeah. And on a tumor board, if you will, right? Yeah.
Yeah, so we do have our tumor board and we meet. We don't talk about every single case, but I like to think of it as every patient that we see at the clinic is offered multidisciplinary appointments at diagnosis. And so that way we have our own little mini tumor board where I meet with you, we develop our plan, and I say, okay, I'm going to send a note to your medical oncologist and your
Wow.
radiation oncologist. And that way we have communicated about you. And so that's our mini discussion.
That's
Um,
nice.
yeah.
What would you say to some closing remarks as far as the overwhelming amount of information, the anxiety of the disease, the complexity of it? Because I'm probably the extreme, like I understood about 80% of what you were talking about. But most people, especially even myself when I was first diagnosed, so much
Mhm.
of why I did this is because of the confusion and the
Yeah.
complexity, specifically around staging and grading, which just blew my mind because although stage 2B, grade 1, so to have the comfort of knowing, my surgeon called my tumor sleepy, although walnut size, so it's hard for all of
Mhm.
us to digest. Um, all that you said is kind of in my mind, kind of over here. Because we hear estrogen positive, we hear HER2 negative, we hear you're getting in 1 hour's time. Okay. So, and then this whole, and you and I are going to make lymph nodes beautiful together in this project, right? And we're going to
Yes.
show a guard and we're going to talk about
We're
the
going to
fact that
demystify the
we're
topic.
gonna, yep, and we're gonna make it patient friendly so that everyone truly understands the mystery behind how powerful these, these little kidney beans are. So I just want to say thank you for taking the time. But what would you say to someone listening right now who's really just like, whoa, this is
Mhm.
a lot in a nutshell, excuse the expression, or in a kidney bean shell, what to take away from the final thoughts on, the power of the lymphatic system and the sentinel node. How about that?
So I would say
Take a deep
the
breath. Okay.
lymph uh, the lymphatic system is an important part of our body's management of routine day to day and also keeping out unwanted offenders.
I love
And
that.
so it's very important for us, and it can be important information in the processing of unwanted cells like tumor cells in our body and knowledge of what's going on in our lymph nodes, particularly related to breast cancer, can guide treatments. And so we do want to know. That starts with our investigation and imaging and our exam.
Mhm.
And
What's going on, right?
exactly. And the other thing, just to follow up what you were sharing, it's very overwhelming to get a breast cancer diagnosis or to have somebody you loved be diagnosed with breast cancer. And I think that as your mind is spinning from that diagnosis call, even before your first visit, jot your notes down. Hang on to that for your visit and take that with you. Ask questions.
Yeah,
Take an extra set of ears.
yeah, for
Um,
sure.
I like
Yeah.
to write notes for patients because then that means that they're listening and they're
Yeah.
not trying to, you know, furiously
This
write
is
down everything I'm saying. We give resources, most providers do. Um, but bring an extra set of ears, lean on
okay.
to those around you. The only caveat to that is that one little change in, say, a receptor or grade or size or clinical assessment of the node, that could drastically change your treatment. So everybody's journey is truly uniquely their own.
Yeah.
So while it's good
Gotta
to
remember
share
that.
experiences with others, somebody's journey may be just a smidge different and then drastically different.
Yeah. Yeah. Well, can't thank you enough. And I think this resource is going to help many, many people. And just creating the visuals to make it really patient friendly. So again, thank you for this. And, we're just going to focus on how special the lymphatic system is. And also, as I have gone through this, I say to anyone going through this, take a moment to really listen to what Dr. Kopicky is saying and ask your surgeon questions, because I didn't.
Mhm.
That's why I'm doing this, so that we are all more empowered. Because I feel if we truly understand the whole roadway mapping system and all of this that's happening, it can really hopefully calm you down, because your surgeon is going to make sure that they get all
Yeah.
the cancer. And so there's a lot of science. And as Dr. Rosen says, there's a whole orchestra of things that have to happen to get to that finish line, right?
And that's why, patients or newly diagnosed or those with family members have just a wonderful resource like you to lean on with Learn, Look, Locate, and vetted information from your advisors to, I think Dr. Google can be a friend for a moment and then it may not be applicable. And so
Yeah.
coming to a source that you've created, it offers a lot of that information for patients just trying to digest the diagnosis and figure out what questions to ask.
Yeah. Because we do Google and we do want to know. And so my hope is that this interview finds anyone that wants to know from a global perspective. So thank you so much, Dr. Kopicky, and can't wait to get this out for everyone to see it.
It's great working with you, Cynthia. Thank you.